Welcome to FMGE July 2023 recall session by ADrPLEXUS. This is Dr. Chandini here for pediatrics. So hope you have done the exam well. So I have collected around 14 to 15 questions which are from pediatrics. Some of it are integrated with the other subject as well. So we'll quickly try to recall the questions. So now coming to the first question. A child with celiac disease should avoid all of the following except suji, rice, oats and wheat. So they've given you 4 options. They've asked you which the child should eat. It's like double negative, see? Should avoid all of the following except. So they've asked you what the child can eat. So what about suji? So what is suji? Suji is otherwise called as rava. So it is made from wheat. So suji is made from wheat. So you all know that in celiac disease, the children are not supposed to eat something that contains bro. So what is bro? Bro is barley, oats, rye, oats and wheat. So any substance that has these things, the child is supposed to not eat. Coming to suji, so I told you suji is made from wheat, so a child cannot eat suji. What about rice? Yes, in this bro, rice is not there. So rice can be safely eaten by a child with celiac disease. Oats also the child should not eat, and wheat also the child should not eat. So out of these 4 options, rice would be the answer for this question. So now coming to celiac disease. So what is celiac disease? Celiac disease is the most common cause of chronic diarrhea in children more than 2 years of age. So it presents as chronic diarrhea and malabsorption. It is due to sensitivity to gluten. So it is a gluten sensitivity disorder. So usually the features will be like on starting complementary feed, on introduction of all these wheat-like substances, what happens? The baby will present with chronic diarrhea and failure to thrive. Growth retardation. These will be the presenting features in these babies. So this celiac disease is most commonly seen in North India compared to South India, where the staple food is wheat. So it is most commonly seen in North India. These are the clinical features. Now, how to diagnose celiac disease? So you can do a serology and see anti-TTG antibodies. So anti-TTG antibodies. What is TTG? Tissue transglutaminase. So that is one diagnostic test. The second test is you can do a biopsy and see the histopathology. In the biopsy, you will have Bilious atrophy and increased crypt length. And one more finding, intraepithelial lymphocytes. Intraepithelial lymphocytes. These are the biopsy features of celiac disease. Now coming to the treatment, so the problem here is gluten. So anything that has gluten has to be avoided. So total avoidance of these bro substances. Avoid gluten containing diet. So when there is diet modification, all these symptoms resolve. So this is about celiac disease. So from this we know the answer to this question is rice. So rice can be safely given to a child with celiac disease. Now moving on to the second question. So in the second question, an image that is similar to this was given and they have asked what is the diagnosis. So if you see this image, you can see there is some defect from the head of the baby which is extending to the vertebral column, the back of the baby. So what is this kind of defect? Is it anencephaly? No, anencephaly where only the brain of the baby, the forebrain of the baby and the skull of the baby is affected. The spine will not be affected in plain anencephaly. So what is anencephaly? It is a neural tube defect. Anencephaly is a neural tube defect. It affects the forebrain and cerebrum. What happens here? You all know there is a neural tube. So the cephalic end of the neural tube and the caudal end has to fuse. So the cephalic end does not form properly. Because of that, there is a defect in the brain that is called as anencephaly. Now coming to meningocele. So meningocele is nothing but the protrusion of the meninges through the spinal defect. So meningocele you will see somewhere here in the spine. just like your spina bifida. Through the defect, the meninges will protrude. That is protrusion of meninges. What about this option? Craniorachisis with anencephaly. So anencephaly is there, and something called as craniorachisis is also there. So what is craniorachisis? Here, if you see, along with this anencephalic defect, you will have open defect of the vertebral column as well, just as you see in this image. So the head of the baby is also not formed properly, and there is an open defect that is extending to the spinal cord and vertebral column as well. That kind of defect is called as craniorachitis. So the answer for this question is craniorachitis with anencephaly. Now coming to the third question. What is the amount of milk given to a term baby in the first 24 hours after delivery? So they're asking how much you have to give to a term baby. So the clue here is it's a term baby and first 24 hours. So the answer here is 60 ml per kg. So option C is 60 ml per kg is the first day requirement of a term baby. Even if they ask the question as what is the IV fluid for a 24-hour baby, term baby, it is 60 ml per kg. Okay. So what about preterm babies? Preterm babies and weight less than 1.5 kg babies, you are supposed to give 80 ml per kg. Okay. So for a term baby, it is 60 ml per kg. For a preterm of whose weight is less than 1.5 kg, you go with 80 ml per kg. Yes. Moving on to the next question. What is the mid-arm circumference for severe acute malnutrition? So they have given options like 11.5, 12.5, 13.5. So you all know this answer. It's a very direct question. So for diagnosis of SAM, mid upper arm circumference should be less than 11.5 centimeters. So if 11 centimeter was there in the option, that would be the answer for this question. Okay. Now, what are the other criteria for severe acute malnutrition? Criteria for SAM. So you have three criteria. The first criteria is weight for height. It is not weight for age, it is weight for height less than -3 standard deviation. That is the first criteria. The second criteria is mid upper arm circumference less than 11.5 centimeter. The third criteria is presence of bilateral pedal edema. Bilateral symmetrical pedal edema. So any one among this can be taken in the diagnosis of severe acute malnutrition. The catch here is coming to this mid upper arm circumference. This mid upper arm circumference is not applicable in children less than 6 months of age. So if they give you a SAM child who is less than 6 months of age, you're not supposed to include mid upper arm circumference as a criteria. So when we can include only for children from 6 months to 16 months of age. So for less than 6 months, mid upper arm circumference is not included in the criteria. So moving on to the next question. What is the dose of vitamin A in a child of 1 to 8 years? So I hope this was the age group that was given there. So they're giving you 1 to 8 years and how much you will do. So most of the options have 2 lakh international units in their options, and it was like the interval and the duration only changed. So now coming to the vitamin A dose. This is the prophylactic dose they're asking. They're not asking about the treatment of vitamin A. This is the prophylaxis. So how much you will give prophylaxis of vitamin A? So it depends upon the age of the baby. Less than 6 months, 6 months to 1 year, more than 1 year. Okay. So less than 6 months, the dosage is 50,000 international units. And it is oral. Vitamin A is given orally. 6 months to 1 year, the dosage is 1 lakh international units. More than 1 year, the dosage is 2 lakh international units. So you all know it. Here, the answer is going to be 2 lakhs. But what is the frequency? How frequent you have to give? That is the catch here. So for prophylaxis, you have to give every 6 months. Every 6 months till 5 years of age. So this is what is included in the national immunization schedule also. When you start giving your 10th month vaccine, you give vitamin A along with that. And from thereafter, you will give vitamin A every 6 months till the child reaches 5 years of age. So the answer here is option A, 2 lakh international units every 6 months till 5 years of age. Now, what about treatment of vitamin A? If the same is asked as a treatment, the dosage is going to be the same, but the frequency is you have to give 3 doses. Day 0, day 1, day 14. 3 doses. So, on the same day, the next day, and 2 weeks later. So, this is the difference between the prophylaxis and the treatment of vitamin A. Coming to the next question. So, they have given a scenario like a child is having oil drop cataract and with worsening of symptoms like vomiting and all after breastfeeding. So, that was kind of a scenario that was given, and they asked you what is the diagnosis. So, the direct hit here is oil drop cataract. So, where is oil drop cataract seen? Oil drop cataract is seen as a condition called as galactosemia. So, it is galactosemia. Here something called as oil drop reflex also. So please do not confuse with cataract and reflex. Oil drop reflex is seen in keratoconus, whereas oil drop cataract is seen in galactosemia. So now we will see why a baby gets cataract in galactosemia. So galactosemia is a inborn error of metabolism, of carbohydrate metabolism. Now what happens? The baby drinks lactose that is present in the breast milk. So what happens to the lactose? The lactose, it's acted upon by lactase and that converts into glucose and galactose. Now, this galactose has to be converted to glucose to undergo glycolysis. So, how this happens? This galactose gets converted to galactose 1-phosphate with the enzyme called as galactokinase. Now, this galactose 1-phosphate gets converted to glucose 1-phosphate. Here you have an enzyme called as galactose 1-phosphate uridyl transferase. Okay, uridyl transferase. So, what happens in galactosemia? You have two types. One is a classical type of galactosemia where the enzyme that is deficient is galactose 1-phosphate uridyl transferase. So, you don't have this enzyme. So, when you don't have this enzyme, what is going to happen? The first thing is that this is going to get increased. So, because of accumulation of galactose 1-phosphate, you have so many abnormalities in the baby which presents at fever, vomiting, jaundice, hepatomegaly, and all these features. Now, because of increase in galactose 1-phosphate, we have those toxic effects. Now, the other thing is the product is becoming very less because you don't have the enzyme. So, this glucose is going to reduce, and what is going to happen in turn? You will not have glucose, and you will have hypoglycemia. Hypoglycemia. So, this is the feature of classical galactosemia. Now, what happens here is this galactose which gets increased because galactose 1-phosphate is also increased, so you will have more amount of galactose which is not being metabolized. This increased galactose gets converted to a compound called as galactitol. This galactitol gets deposited in the lens of the baby and produces cataract. So that is why you get cataract in galactosemia. So the reason is because of the accumulation of galactitol. So that is the feature of classical galactosemia. Okay. So what happens to this cataract? This is a reversible cataract. Wow. Once the baby is stopped giving breastfeeding, when lactose containing food is stopped, immediately what happens? The baby will start recovering, and as you goes, the cataract will also get reversed. So that is the capture. So it is a reversible cataract. Oil drop cataract is seen in galactosemia. Now let's see about the other named cataracts. Sunflower cataract. Sunflower cataract is seen in Wilson disease. Okay. Christmas tree cataract. Christmas tree cataract is seen in myotonic dystrophy. Okay. So the answer for this question is galactosemia. Now moving on to the next question. A neonate presents with recurring vomiting after breastfeeding with jaundice. Urine shows positive Benedict test. What is the enzyme deficiency? So just now we have seen a similar scenario. So what is the clue here? Recurring vomiting after taking breastfeed, and there is jaundice. Urine shows positive Benedict test. That means there is reducing substance in the urine. Reducing sugar is there in the urine because galactose is there. Now, but glucose will not be there. If you test the urine for glucose, you cannot detect glucose, but reducing sugar, that is galactose, is present. So that is what is given in this scenario. What is the enzyme that is deficient? Just now we have saw the enzyme that is deficient is galactose 1-phosphate uridyl transferase. So this is a scenario of typical galactosemia baby. So the scenario will be on 2 to 3 days of life after starting breastfeeding, the baby presents with vomiting, failure to thrive, jaundice, hepatomegaly, hypoglycemia, urine shows positive, reducing sugar, no glucose. What is the diagnosis? So it is classical galactosemia. The enzyme that is deficient is galactose 1-phosphate uridyl transferase. Now moving on to the next question. A child was brought to the OPD with recurring infections and his height for age is less than -2 standard deviation. So height for age less than -2 standard deviation. What is the correct term for the above given condition? So they've given you 4 conditions: wasting, underweight, malnutrition, stunted. So less height for age means what? Now let's see. Move on to the options. Wasting. So when you say wasting, when weight for height is less. So you plot it in weight for height chart. If it is less than -2 standard deviation, you call it as wasting. Underweight is when weight for age is less. So when weight for age is less, you call that as underweight. Malnutrition, just now we saw, we will see these criteria, your wasting as well as weight for height for SAM. Weight for height, mid upper arm circumference and edema. These are the things to say it is SAM. What about stunting? Stunting is where you see height for age. Height for age is seen in stunting. So when height for age is less than -2 standard deviation, you will say the child is stunted. So the answer here is option D, stunting. Now moving on to the next question. A child presents with SAM, severe acute malnutrition and severe dehydration. What is the IV fluid of choice? So a little confusion here is whether they have asked what is the fluid of choice or IV fluid of choice. So the answer depends on what is being asked. So what higher Greek called is, most of them have told IV fluid of choice has been asked. So we will discuss both the scenarios. So you all know in dehydration you give ORS and RL. Whereas SAM with dehydration is going to be a different scenario. It's not going to be the same as any child with dehydration. When a SAM child presents with dehydration, first thing we have to do is whether the child is in shock or not. So if the child is not in shock, it's only dehydration, you will go with something called as resomol. So what is resomol? Resomol is rehydration solution for malnourished children. Rehydration solution for malnourished. It is nothing but an ORS. ORS, that is not standard ORS, but it is a different ORS. So now what you will do, you will take our normal WHO ORS and you will mix this ORS in 2 liters of water. And you will have 50 gram of sucrose and 40 milliequivalents of potassium chloride. Okay. So this is how you make our normal ORS into resomol. So normal ORS, you mix it in 1 liter of water. But to make resomol, what you will do, you will mix it in 2 liters of water, add 50 grams of sucrose and 40 milliequivalents of potassium chloride. Okay, this is resomol. So for dehydration with no shock, you will give resomol. How much you will give? 5 to 10 ml per kg per hour for 12 hours. Slow rehydration over 12 hours you will give. So this is one scenario. Suppose they ask severe dehydration, shock and IV fluid, as in this case. If the child presents with shock, you will start IV fluid. So what is the IV fluid for choice in shock? In any shock, you will prefer normal saline. But in case of SAM with shock, you will prefer ringer lactate with 5% dextrose. That will be your first choice. If that is not there in the option, the second choice would be half normal saline with 5% dextrose. If even that is not in the option, you will go with plain RL. Right? Then how much you will give? You will give 15 ml per kg per hour and you will reassess. After an hour, you will check. If the shock is corrected, you will give another 15 ml per kg. Okay. Suppose if shock is not corrected, even after 1 hour, you will treat as septic shock. So this is the treatment guidelines for SAM with shock. So now as they have asked what is the IV fluid of choice, we will go with RL with 5% dextrose. I hope that was there in the option. If they have not asked about IV fluid and if they have asked what is the next line of management, the answer would go with Resomar. Fine? Because here they have not mentioned the child is having shock. It is only severe dehydration. Moving on to the next question. So an image similar to this was given. So image similar to this was given and they have asked what is the genetic abnormality here. So what is this? As you see, there is a single transverse palmar crease. Usually we all have double palmar creases, transverse. Whereas here you can see a single transverse palmar crease. This is called as simian crease. So simian crease is seen in which syndrome? It is seen in Down syndrome. So they have asked this Down syndrome karyotype. So you all know Down syndrome is trisomy 21. So trisomy 21. So this 21st chromosome we have double. So the karyotype will be 47 plus XX or XY. It depends on male or female. It is 47 chromosome, but sex chromosomes are not affected. It is the trisomy 21. That is Down syndrome. So what are the other features you see in Down syndrome? So coming from head to foot, you have flat occiput, brachycephaly, small head, and you will have a characteristic mongoloid slant. So what is mongoloid slant? The outer canthur of the eye will be at a higher position than the inner canthur of the eye. Then you will have hypertelorism. So mongoloid slant, hypertelorism. Hypertelorism is there is a wide gap between the two inner canthi and flat nasal bridge. Open mouth, fissured tongue, and low set ears. These are the facial dysmorphic features of Down syndrome. Okay, so simian crease has been asked and karyotype was asked. It is trisomy 21. It is Down syndrome. Okay. Coming to the next question, you had another question on Down syndrome. In which trimester quadruple test is done for antenatal screening of Down syndrome? So first we have to know what is quadruple test and what are the tests we do for Down syndrome. So you have some tests in the first trimester. What are the first trimester tests? You will do beta HCG and you will do PACE. Okay. So beta HCG and beta human chorionic gonadotropin have a placenta associated pregnancy associated placental protein A. So these two are done in the first trimester. So coming to the second trimester, you do an ultrasound test for nuchal translucency, NP scan, nuchal translucency. So if it is more than 3 millimeter, it is abnormal. And what about the blood test? So you will do beta HCG, you will do serum alpha fetoprotein, AFP alpha fetoprotein, unconjugated estriol, and inhibin A. So what about these values? Beta HCG and inhibin A will be high. The other two will be low. So high will be high. Beta HCG and inhibin high will be high. Okay, others will be low. So if these three tests are done, beta HCG, AFP and unconjugated estriol is done, that is called as triple test. If all the four are done, beta HCG, AFP, unconjugated estriol and inhibin A, that is called as quadruple test. So this is what they asked. So when do you do quadruple test? It is done in the second trimester. So option B, second trimester, is the right answer for this question. Now moving on to the next question. A neonate is admitted to the hospital with bilious vomiting. So the clue here is baby is having bilious vomiting. His abdominal X-ray is shown below. What is the likely diagnosis? So they are given an X-ray that is similar to this. What is here? You see a double bubble sign. So the clues are bilious vomiting and double bubble sign. So the answer here is duodenal atresia. Duodenal atresia. So what are the features that you see in duodenal atresia? One characteristic hallmark feature is bilious vomiting. The next feature is no abdominal distension. Okay. So the baby presents with bilious vomiting without any abdominal distension. So what you do an X-ray, you see the double bubble appearance and you do surgery. So you will cut this and loop it. Duodenostomy is what is done. So surgery is the corrective procedure for this. So this is duodenal atresia. Now coming to this other option that is given, CHPS. So what is CHPS? Congenital hypertrophic pyloric stenosis, otherwise known as idiopathic hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis. Now, how to differentiate between this duodenal atresia and pyloric stenosis? So, based on the features, the presentation of pyloric stenosis will be around 3 weeks of age, whereas the presentation of duodenal atresia will be around immediately 24 to 48 hours after birth. Okay, so the presentation will be early, whereas in hypertrophic pyloric stenosis, it's going to be around 3 weeks of age. And then in hypertrophic pyloric stenosis, you have non-bilious vomiting. That is characteristic because the obstruction is before the duodenum where the bile duct is coming and emptying. So you will have non-bilious vomiting. And you will have a olive-shaped mass in the epigastrium. You will have an olive-shaped mass in the epigastrium and visible gastric peristalsis. These are the features of hypertrophic pyloric stenosis. The baby presents with vomiting and electrolyte imbalances, right? Hypokalemic, hypochloremic, metabolic alkalosis. So that is the feature of hypertrophic pyloric stenosis. But here they are given bilious vomiting and a characteristic double bubble sign. So the answer is duodenal atresia. Now going to the next question. Which of the following deficiencies is associated with poor wound healing, diarrhea, dermatitis and alopecia? So this is a direct question. So the answer here is zinc deficiency. So all these features are due to zinc deficiency. So what are the features of zinc deficiency? So you will have chronic diarrhea, skin lesions, dermatitis-like lesions, alopecia, wound healing is delayed, and one more important thing, hypogonadism. And you have an inherited disorder of zinc deficiency due to absorption of zinc, that is called as acrodermatitis enteropathica. That is an autosomal recessive condition. Acrodermatitis enteropathica. Autosomal recessive condition which presents with lesions over the periorificial areas. So what do you mean by periorificial lesions? So you will have lesions around the mouth, around the anus, around the nostrils. So anything that has an orifice will have lesions. So you will have periorificial lesions, diarrhea, alopecia and all that. That is acrodermatitis enteropathica due to malabsorption of zinc. So coming to the other options, what about niacin deficiency? Niacin deficiency presents with pellagra. So here also you will have 4 Ds. What are the 4 Ds? Dermatitis, dementia, and death. So these are the 4 Ds of pellagra. So whereas in zinc deficiency, you will have this alopecia and poor wound healing also. And what about vitamin C? Vitamin C can also have poor wound healing, but the other features are not going to be there. So it will present with scurvy-like features. Scurvy, that is delayed wound healing because of loss of this collagen and bleeding manifestation. So it is not going to have this alopecia, diarrhea, and all that in scurvy. So the answer for this question is zinc deficiency. Now moving on to the next question. So they've given a scenario. They're not directly told it is a measles case, but they've given a scenario to say it is a measles case. So the scenario was somewhere like a child presented with rashes, with maculopapular rash and fever, which started behind the ear. So this was the scenario. They've asked, what is true about this condition? So what is true about this condition? So you all know this type of feature is a feature of measles. So what is true about measles here? Polymorphous rash, coryza, cough, and conjunctivitis. So polymorphous rash is something characteristically seen in varicella infections. In chickenpox, you have polymorphous rash, in vesicular rash, and all that on erythematous base. That is a varicella. That is not a measles. In measles, you have a sandpaper-like maculopapular rash that is present in the face, trunk, and the extremities. Now, the next option is cough, coryza, and conjunctivitis. Yes, these are the 3 C's of measles. You will have cough, coryza, and conjunctivitis-like features. You will have fever. So, how will measles present? You will have fever and these 3 C's. Along with this, on 4th day of fever, the baby will present with rash that typically starts behind the ear and progresses over the face and to the trunk. Okay. So how is the rash? It is a maculopapular rash. What is the pathognomic sign of measles? You have something in the oral region and anatom that is called as Koplik spots. So the Koplik spots usually presents before the rash. 1 to 2 days before the rash, the Koplik spot presents. Koplik spot is an oral mucosal lesion that is present in the buccal mucosa just opposite to your lower second molar. That is called as Koplik spots. Then you have the rash. So this is the presentation of measles. Now coming to the complications of measles. Most common complication of measles is acute otitis media. That is the most common complication. Most common cause of death in measles is pneumonia. That is the most common cause of death in measles. Now, most common rare late manifestation of measles, which occurs after 10 to 15 years after episode of measles. That is called as SSPE. So, what is SSPE? Subacute sclerosing panencephalitis, which affects the child after 10 to 15 years of having the primary measles infection. So here the child will present with abnormal behavior, the school performance will be low, sleep disturbances, and myoclonus. It is almost a fatal incident. So SSPE is very rare, but when it comes, it is going to be a fatal event. So this is about measles. Now coming to the last question for today. HIV positive mother delivers a baby. What is the initial treatment of this neonate? So I hope this was the scenario that was given. So if it was plainly asked like an HIV positive mother delivers a baby, the answer would be nevirapine. So any HIV positive mother after delivery, the baby should be started on nevirapine. So how much nevirapine you give? 2 milligram per kg of nevirapine for 6 weeks. So this is going to be the treatment guidelines for a baby born to HIV positive mother. Suppose they have given a scenario where the newborn is a high risk newborn, then the treatment is going to change. High risk newborn born to HIV positive mother. So what is this high risk category? So the recent edition of OPCI, these 4 categories are mentioned as high risk category. The first thing is if the mother has received only less than 4 weeks of ART before delivery. So the mother has taken only 4 weeks of ART, less than 4 weeks of ART before delivery. Second, if the mother was diagnosed in the postnatal period only. So throughout the pregnancy, the mother was not diagnosed. Mother was diagnosed only in the postnatal period. Next, third category is the RNA, HIV RNA copies are more than 1000 copies per ml within 4 weeks of delivery, before delivery. Then that becomes this is also for the mother, high risk category. Then one more category is mother acquired infection only during pregnancy. Acquired infection during pregnancy. Okay, these four are high risk categories. If a scenario is given, suppose like mother was diagnosed with HIV only after delivery of the child, then it becomes a high risk category. Or if it's given the mother has not taken ART throughout the pregnancy, delivered a child, then that will become a high risk category. Now, what to do with this high risk category? When this newborn is one among these four categories, you have to give nevirapine plus zidovudine. Nevirapine plus zidovudine for 6 weeks. Okay, so a plain baby born to HIV positive mother was taken ART. It is only nevirapine. Suppose if it falls in any of the four categories, you have to give two drugs, nevirapine and zidovudine for 6 weeks. So this is about the initial treatment that you give to a baby that is born to HIV positive mother. Now what to do after that? So you have started on nevirapine. Now what to do after that? So the baby is there. So what you do a HIV test. HIV test. What test you do? HIV PCR total RNA. HIV PCR total RNA should be done using a dried blood spot. When you will do? At 6 weeks. Okay, HIV PCR total RNA. It is not RNA, total RNA plus DNA. It is total nucleic acid, TNA. Okay. It is not RNA or DNA. It is total nucleic acid. At 6 weeks, you will do this dried blood spot. Okay. Now, after doing this, what you will do? You will see whether it is positive or negative. Suppose if it is positive, you will send the same test with whole blood. Whole blood, you will send the same test. If that is also positive, you will start ART. Okay. Suppose if it is negative, you will do another DBS at Bilious PCR TNA at 6 months. Okay, fine. So now what to do? At 6 months, again you will see whether it is positive or not. If it is positive, what you will do? If it is positive, what you will do? You will again start, confirm and start ART. Suppose if it is negative, what you will do? You will do another test at 1 year of age. When at 1 year, what you will do? You will slowly stop the breastfeeding over 1 month, and after stopping breastfeeding for 1 month, you will do this DBS again. Okay, so you will see whether it is positive or negative. Again, if it is positive, you will start ART. If it is negative, another test you will do at 18 months of age. So these are the protocol what you have to follow for a baby who is born to a HIV positive mother. So one test at 6 weeks, then at 6 months, then at 1 year after stopping breastfeeding, then the last test at 18 months of age. If anywhere the baby becomes positive, you will start ART. Or if anywhere the baby becomes symptomatic, you will start ART. Yes. Nevirapine and zidovudine, you will continue up to 6 weeks and then you will start. And one more thing, you will start on clotrimazole prophylaxis. Okay, so as long as the baby is declared that the baby is not having HIV, you will continue the baby on clotrimazole prophylaxis. Okay, so the answer here would be nevirapine. So the answer for this question is nevirapine. So this was the last question for today. So we have seen almost 15 questions that has been asked from pediatrics in FMGE 2020. If you have any more questions, please do ping us and we'll recall that also. Thank you so much.